Can you guys see the screen?
Yes.
Okay. So some important concepts that you really need to know is one, the two different types of circulation. So it's all one, but it's one circulation system is actually going into the lungs where that oxygen is being uh, put into the blood, okay, and carbon dioxide is being moved. That's your pulmonary circulation. So that's really happening when the blood comes back from the body. It comes back from that vena cava, okay, it goes into the right atrium, then it goes through your tricuspid valve, and it's going to end up from that tricuspid valve in the right ventricle. And then from that ventricle, it's going to go into that pulmonary circulation. And in that pulmonary circulation, it's going to send it over to the lungs, and the lungs are going to oxygenate it. You also have systemic circulation. So once the blood comes back into the left atrium, okay, it's going to come into the left atrium, and then it goes into the bicuspid valve or the mitral valve, into the left ventricle, up to the aorta, and out to the body. Now it's oxygenated, and that is just your systemic circulation, meaning that it's going out into your system. Okay. If there's a problem with your lungs, it's going to affect the right side of your heart because the right side is where that blood is coming from and going in to the lungs. So if there's a problem with your pulmonary valve, or if there's a problem with your tricuspid valve, okay, that's going to affect the right side of your heart. On your left side, you have your mitral valve or your bicuspid valve, and you have your aortic valve. So if there's a problem with one of those valves, that's going to affect the left side of the heart. If the right side of the heart is damaged, that would cause a problem or backup into the body. Okay. Why? Because the blood that's going into the right side of the heart is coming from the body through that vena cava. There's a problem with the left side of the heart. That's going to back up into your lungs. That's going to cause congestion there because the fluid coming in to the left side of the heart is coming from the lungs. Everybody got that?
Yes. Yes.
Anybody have questions on any of that? All right. So you have the blood coming from that vena cava, okay, is going into the right side of the heart, and it's the superior and inferior vena cava. All that blood coming in there on the right side of that heart is deoxygenated because that blood already went to the body. It got used, and now it has to come back and go into the lungs so that it can get oxygenated again. Okay. The only way that can happen, it has to come back into the right side of the heart. So we have that deoxygenated blood from the vena cava coming back into the right side of the heart in the right atrium, goes through the tricuspid valve into the right ventricle, from the right ventricle through that pulmonary valve into the pulmonary artery. Okay. And then it goes to the lungs so that it can get oxygenated. The left atrium is now going to be filled up with that blood coming back from the lungs. Okay. It's going to be filled up with oxygenated blood. Once it fills up, it will contract. That's going to force that mitral valve open, allow that blood into the left ventricle. Once the left ventricle is full, that mitral valve is going to close, and the left ventricle will contract and shoot that blood up through the aortic valve. Okay. And that's how it's going to get out to the body. You just basically, as far as the anatomy, you need to know the layers of the heart. Okay. The epicardium, the myocardium, the endocardium. Those are your layers of the heart. Okay. Epa is going to be the outermost part. Myo is going to be the muscular part, and endo is the innermost part. And those valves, your AV valves and your semilunar valves. The septum, that separates. So in that epicardium, there's fluid there that helps with the friction of the heart. It lubricates it. That muscular part of the heart, that myocardium, it's a muscle. So that's responsible for the work of the heart. So that's going to help the heart contract. It also produces certain cells there. They're special cardiac cells. And those cells help it contract in a specific rhythm and with a certain amount of force so that it can get the blood out everywhere. Then the endocardium, that's covering those inner chambers of the heart and the valves, and it's protecting that area. It's a lot smoother to help the blood flow through. And it actually forms those valves to separate the different chambers. The left ventricle is a little bit thicker. That's where your pump is, your big bad pump. And it's thicker because that's where the real work is happening from there. That ventricle has to contract hard enough to shoot that blood up through the aorta against the resistance that's coming from the body and out to all the vessels. You got to know those four valves: aortic, pulmonary, mitral, and tricuspid. Okay, tricuspid, I remember it's on the right side of my heart, 3 valves. My right side is my strong side of my body. That's how I try to remember it. Left side is mitral valve. It only has 2 cusps. So for that, I remember it's less cusp. It's on the left side of my heart. However you have to remember it, you have to remember it because the valves that are there are going to affect that side of the heart. So if they're asking you about right-sided heart failure, then you have to remember that right-sided heart failure can be affected by the pulmonary valve or the pulmonic valve because it's on that side of the heart, by the tricuspid valve because it's on that side of the heart. If they're asking about left-sided, okay, your mitral valve is on the left side of the heart. Your aortic is on the left side of the heart. So those are the valves that are going to affect the left side of the heart, as well as hypertension is going to affect the left side of the heart because I just said when the blood pushes out of that left ventricle into the body, it has to go against the resistance coming back in that vessel. So if someone has high blood pressure, that vessel that goes up through the aortic and out to the body, it's going to have a higher pressure in it. The body's going to have to push harder against that if they have high blood pressure. So it's going to affect that left ventricle, make it thicker, meaning less blood can get into it. And that's going to make it less efficient. Any questions on that? The valves keep the blood from leaving the heart in the wrong direction. So the blood has to flow through the heart one way. Why? Because if it regurgitates or if it flows backwards, then it can cause it to pool and clot. And that could be a death sentence or at least a stroke sentence, which is sometimes worse than a death sentence. AV valves separate the atria from the ventricles. So that is your tricuspid and your mitral valve. Those are the AV valves. And for those valves to work, okay, the atrium where that valve is, so like for the tricuspid, that right atrium will completely fill up first, and that pressure will force the valve open. Then it goes into the ventricle. That ventricle is going to completely fill up before it contracts, or it's supposed to if it's working right. Semilunar valves are your aortic and your pulmonary valves. And these are located wherever the vessel exits, okay, to the area it's going to. So like the aortic, it's the aortic valve is going to be near where that aortic vessel exits the heart. Same thing for the pulmonary valve. It's going to be where that pulmonary vein exits the heart. That's where the valve is located. The pulmonary valve will close as the right ventricle is filling up with blood. And when the right ventricle is completely full, it'll force that pulmonary valve open and then the blood goes through it. The same thing with the aorta. The left ventricle will completely fill, okay? And then it's going to force that valve open. The septum, its job is to separate deoxygenated from oxygenated blood. Why do you have to know that? Because sometimes people have a defect in the septal wall. So if the wall is supposed to separate the blood and it's not separated, then that means oxygenated and deoxygenated blood could potentially mix. And when that happens, you're going to see certain symptoms in your client. It could be life-threatening too, depending on how bad the defect is or what the issue is. You have to know about the conduction system. And this you really have to know. So let me see. Let me just pause this for a second here. Just want to see if I could pull up a better picture here. Okay, so your main things there to remember again are the P wave is depolarization of the atria, the QRS is depolarization of the ventricles, and the T wave is repolarization of the ventricles. So whenever that impulse happens, we'll see a change in the electrical activity. That's why we use that EKG. Usually it starts in that SA node. It goes to the AV node, to the bundle of the Purkinje fibers, and then to the ventricular area and out to the heart itself. The medulla is controlling the cardiac. Okay, it controls the heart rate, it controls the contractions. You also have receptors in the aorta and in the carotid arteries. Those help detect things like blood pressure. And then your sympathetic nervous system and your parasympathetic nervous system, which can stimulate the heart to do different things by altering the rate and the force of contractions. So, like sympathetic can increase the heart rate and cause tachycardia. Parasympathetic can stimulate the vagus nerve and slow down the heart and cause bradycardia. So, when we use blood pressure medications, they work off of those principles of those beta receptors that trigger either the sympathetic nervous system to block some sort of action. So, like your beta blockers, they can block the sympathetic nervous system so that we don't develop that tachycardia. This can help with someone who's had an MI or someone that has SVT or AFib. They can give them this beta blocker so that the heart doesn't continue to beat fast and do additional damage, and also so that it doesn't increase the workload of the heart. Because if you increase a diseased heart, if you increase the workload on it, eventually it can cause it to fail. So you don't want to do that. You should also be familiar with the factors that can increase the heart rate. Okay, like thyroid hormones, your body produces epinephrine, elevated body temperature, infections. high, humid, hot temperatures, working out, exercising, or, moving a refrigerator, shoveling the snow, smoking, stress, pregnancy, pain. Then you have coronary arteries. These coronary arteries, they bring blood flow, okay? The main one I talked about was the left anterior descending one. We call that the widowmaker. Usually, if something happens there, that's going to affect the left side of your heart, which is where your pump is. So we call that the widowmaker because that's what it typically makes people. A lot of people that have these types of heart attacks don't survive. We're getting better at it, but it's still a known fact that a lot of these people don't survive. The heart is a muscle. Remember, that's the myocardium. That is responsible for the rhythm, for the contractions. These coronary arteries are feeding the blood supply to that muscle. So usually when someone has an MI, it's blockage in one of these coronary arteries, and the blood can't get to that muscle for the heart to do its job. So it's interrupting that heart's ability to do the job. When the heart is in diastole, it's relaxed, okay? And that's when the majority of the blood flow occurs. When it's in systole, it's contracting. And so the blood and the muscles are being compressed. So there's less blood flowing through at that time. That's why if someone has like AFib or VFib, it's a problem because the heart is constantly contracting. There's no resting phase there, and blood flow is not occurring. So there's a decrease in cardiac output. Also, remember you have those specialized cardiac muscle cells there in the myocardium. They're also not getting flow. Now, sometimes little vessels within the heart will connect together, make these direct connections called anastomosis. They make these little connections there and they form something called collateral circulation, just like you heard about in the brain, where these little vessels can help if there's damage to the heart by making sure that blood flow gets to some of the other areas. So, one of the reasons why exercise is important, it can increase that collateral circulation for people. That's something I would probably know. This can help if an artery were to become obstructed. If these little vessels can pick it up, it might be able to maintain blood flow to at least some of the area. But it's limited to what it can do and it's not foolproof. All right, you want to be aware of the cardiac cycle. So, first, the cardiac cycle is going to be the start of one heartbeat to the start of another. That is what consists of the cardiac cycle. And there's alternating phases of diastole, which again is the relaxation phase, and systole, which is the contraction phase. More blood during diastole, less blood during contraction. So it starts with the atria being relaxed and that blood coming in from that inferior superior vena cava. Goes into the right atrium. At the same time, the pulmonary veins are going into the left atrium. So both of these atrial are filling up. One's filling up with blood from the body that is not oxygenated, and the other one is filling up with blood from the lungs that is oxygenated. So both atria, right and left, are filling at the same time. Remember, both atria will fill up completely before those valves are going to go open. So on the right side of the heart, Once that atrium's completely full, that tricuspid valve is going to open. On the left side of the heart, once that atrium is completely full, that mitral valve is going to open. That pressure, okay, is going to increase there. All right, so now we have both atriums completely full. Tricuspid opens, blood moves from right atrium to right ventricle. Mitral valve opens, blood moves from left atrium to left ventricle. Now the ventricles are going to completely fill. Okay, so on the right side, we have the ventricle filling with that unoxygenated blood. Remember, that's getting ready to go up through that pulmonary valve into the lungs. Okay, through that pulmonary artery and into the lungs. So it goes through the pulmonary valve, into that pulmonary artery, and into the lungs. On the left side of the heart, when that left side ventricle fills, it's going to go through that aortic valve and into the body. And we have oxygenated blood now leaving the heart and going out to the body. Any questions on that? It's all happening together at one time. Okay, so the pressure of the blood in the atria increases and those AV valves open, the ventricles relax. That allows the blood to flow into those ventricles. Then the conduction is going to stimulate the atrial muscle. That's coming from that SA node. So remember, we said the signal leaves the SA node, that's your pacemaker, and it goes to the AV valves. So this is what's happening here. When it gets to that AV valve, remember I said that electrical signal is delayed. So now it's delayed, the valves open and the ventricles are filling. Once the ventricles get filled, those valves are going to close and that stimulation is going to start back up again. It's going to move down to the bundle of his, to those Purkinje fibers. Okay, these ventricles are going to fill up. When it gets down there, it's going to stimulate the ventricles and they'll simultaneously contract and release that blood. One will release the blood to the lungs for reoxygenation, and one is going to release the blood to the body for that oxygenated blood to get out to the tissues. Okay, so right side is sending it to the lungs to get oxygenated, left side is sending it out to the body. How we doing?
We're good.
Sounds. Okay, lub dub is the closure of the AV valves. And dub is the close of those semilunar valves. Murmurs are usually caused by incompetent valves. So sometimes murmurs are not really that serious. But a lot of times it's caused because the valve doesn't close all the way. Usually it makes like a swishing sound or a turbulence. It could also be caused by a hole in the septum. So sometimes kids will have these or born with them and they're really minute and they'll go away. Other people may have to have some sort of surgical procedure done. The pulse, the reason why we check the pulse bilaterally and we compare it against the apical pulse is because we need to know if there's any deficits. Is it weak? Is it irregular? That can indicate a problem. Apical is at the heart itself. And then if there's a difference between the apical and the radial, that is called a pulse deficit. Pulse points, these are areas on the body where we can check the pulse. There's lots of them. Cardiac function. So you should know these terms. Cardiac output. This is the amount of blood that the ventricle ejects every minute, and it's equal to the stroke volume times the heart rate. The stroke volume is the amount or the volume of the blood pumped out of the ventricle during a contraction. Preload is the amount of blood that's coming back to the heart. So that's the blood that's going into the right atrium. And afterload is the amount of force that it requires for that left ventricle to eject that blood out. And usually they measure it on right and left side. Now, on left side, you can have, on right side, you can have resistance too. We'll talk about that. People can develop something called pulmonary hypertension. They have too much resistance from the right side of the heart trying to push the fluid into the lungs. That's from a certain type of damage, and it's called pulmonary hypertension. At rest, the body can pump out in 1 minute the amount of blood equal to the entire volume in the body, which is pretty incredible. So normal heart can increase its rate and put out 4 or 5 times what the minimum volume is if it needs to. With the stroke volume, it can vary with sympathetic nervous system stimulation and venous return. So there can be an increase in the amount of blood returning during exercise. That can stretch the heart, and the force of contraction can increase. During exercise, stress, or infection, cardiac output can increase considerably. Systolic pressure, that's your higher number. And that is when the blood is ejected from the ventricles. Specifically the left one, okay? Because that's what we're talking about there. Diastolic is the lower value. So this is the pressure when your ventricles are relaxed. And that's the lower number. Blood pressure can be altered by cardiac output, by peripheral resistance. And then you have pulse pressure, which is the difference between the diastolic and the systolic. So we take the systolic and we put the diastolic under it and we subtract. And that is your pulse pressure. It's usually around 30 to 40. Your blood pressure can be adjusted by those receptors that I told you about in those arteries. And that can send a signal to the control center in the medulla to adjust the blood pressure. So like if you were to jump up quickly, okay, your blood pressure is going to drop immediately because of gravity. But you have something called reflex vasoconstriction mechanism, and that's going to kick in to protect your brain so that the blood pressure going to your brain remains constant. In older adults, sometimes they have a problem with orthostatic hypotension, and it's because some things aren't working that well in them anymore. But this can also be affected in someone that's been immobilized for a long period of time, which you should have learned this week on your quiz. Blood pressure can be elevated when your sympathetic nervous system is stimulated. So the sympathetic nervous system and the epinephrine can act together to increase the rate and the force of contraction. They can also increase vasoconstriction. They can stimulate the receptors in the skin and the organs. This can help increase the blood return back to the heart. I would know this slide. Just know how to do the calculation. You're probably not going to have to do one, but you want to know what cardiac output definition is. So they don't really test you on diagnostics, okay? But x-rays are used so we can see the size. Cardiac cath helps us tell about the flow. And angiography also about the flow. Cardiac cath can also look at pressures and it can look at the valve function there. So this next one is just showing you, like, if there was a blockage, that angiography could show us the blockage and we could actually put a stent or a balloon in there right at the moment. At the same time, we do that to try to fix it. All right. So next, we're going to talk about coronary artery disease, ischemic heart disease, and acute coronary syndrome. So angina pectoris, you have to know what this is. You have to know the difference between when someone's having angina and when they're having an actual MI. So whenever they're not getting enough oxygen to meet the demands on the heart, they're going to have this chest pain. And it can come in a couple of different ways. So classic means anytime they do something like they try to shovel snow, or they try to do something that's too exertional, they might experience this chest pain. The classic thing for this is sit them down and give them nitro. You got to sit them down because nitro plummets the blood pressure. So don't leave someone standing when you do this. But usually, if you sit them down at rest, that's going to start to alleviate the chest pain right there. Variant is when they have these vasospasms at rest. The problem with the vasospasm is it's a spasm. So it can prevent the blood and the oxygen from getting there. And if they had them back to back, okay, this could cause an MI. Unstable is dangerous. This is prolonged pain at rest, and a lot of times this happens before an MI. Now, if you guys have people that have variant angina, you probably give them something called isosorbonitrate, and you give it to them like 3 times a day. And that's what we usually give them for that. If someone has classic angina, they'll now have a bottle of nitro. They keep on them all the time. And if they have the angina, they'll take the little pill under their tongue. They have unstable angina, we're typically call a 911. Here in angina, we have a reduced blood supply, and it can be caused by obstruction, or partial obstruction is really what we see with this. Because if it's fully obstructed, then it's going to be an MI. When it's partially obstructed, and it can be obstructed because of plaque in the vessel, something sticking to that plaque, a piece of that plaque breaking off, called an atheroma. I would know that term. Or a spasm in the artery can also stop the blood supply and the flow there. Usually they're slightly imbalanced. Okay, so anytime there's an increase in cardiac demand for these clients, it causes the lack of oxygen to that area, and that produces the chest pain. The atheroma is a plaque or a piece of plaque that develops in the wall, okay, and it can break off. So this is people with coronary artery disease who experience this, because coronary artery disease is usually caused by excessive plaque. All right, fried chicken, all that good stuff you're eating, and now it's accumulated in the walls of the blood vessels. So this can cause recurrent intermittent chest pain. It's usually triggered by some physical or emotional stress. The attacks can vary in severity or length of time. As the coronary artery disease gets worse, the attacks can become more frequent and worse. It's usually relieved by rest and, again, nitro. How would it present? Okay. So usually they're going to call it tightness or pressure in the chest. They might even say they have neck or arm pain. For women, they might say back pain or stomach pain. They also might have pallor, diaphoresis. Pallor meaning they're white. The skin, the color doesn't look the same. They're clammy usually or sweaty. And nauseousness they'll present with. Usually lasts a few minutes or a few seconds sometimes even, depending on how quick we get the nitro in, how quickly they're stopping, how much they pushed it. Sometimes people will ignore the pain and just try to push through. Oh, let me just finish. I only got a couple more minutes. It's just my heart. Okay, so really what it boils down to is the amount of oxygen available. Okay, the body doesn't have it to supply. We have a decreased level of oxygen. The body is not able to meet the demands. And that is going to lead to that chest pain. MI, this you can see on the EKG. Okay, usually with this, the artery is totally obstructed. So, as I said, with the angina, it's usually partially obstructed. But with MI, totally. Atherosclerosis, the most common cause. These are things I would know. Usually the atheroma obstructs it. Test questions, those three. It can be caused by a vasospasm, but not that often. And remember, when we were talking about those coronary arteries, okay, the location is going to be permanent, is going to be, huge factor. And then the size. And we were talking about that when we were talking about collateral circulation. So, how big is the infarct and where is it? Is it that left anterior descending? Okay, because that's your widowmaker. If it affects the right side of the heart, then it could affect your arrhythmias, your rhythm, cause arrhythmias. Because the right side of the heart controls what?
Is the right side the lungs?
Conduction. The right side is where conduction is. When we talk about rhythms, okay, we're talking about conduction. So on the right side of the heart, that's where your pacemaker is. If there's damage to those right coronary arteries, you're at high risk for having an arrhythmia. Also, most common cause of death within an hour of an MI is an arrhythmia, but not just an arrhythmia, VFib or VTAC usually. The type 1 MI happens if the coronary artery is totally obstructed. You have to know that, leading to ischemia and cell death. The most common cause is atherosclerosis with the thrombus. Have to know that. Most infarctions are transmural, meaning that they involve all three layers of the heart, the epicardium, the myocardium, and the endocardium. A majority involve the critical left ventricle. Why is that a problem? What does the left ventricle do? What's the
Puts
left?
the blood out to the body.
Yes, it's the big bad pump, the left ventricle. So it's classified as either STMI or non-STMI. Again, they look at the EKG. Type 1 associated with atherosclerosis and the destruction of cardiac muscle. There's other types as well. Type 2 is from a mismatch. So the body's oxygen demand exceeds its available supply. That's what it means. Type 3 are only MIs that kill people. So if it's fatal, it's a type 3. And type 4 and 5 are like, let's say if we were doing an angiocath on someone and we were trying to put a stent in and they had an MI. That is type 4 and 5. So type 4 and 5 is any type of MI that occurs because of a medical procedure. So we were trying to do something. Whenever you do a cardiac procedure on somebody, usually you're going to tell them the risk factors. And one of those risk factors is it can produce an MI. So that would be type 4 and 5. I would know those. Signs of an MI, I would know. So usually we have pressure, heaviness, burning, especially with an increase in activity, shortness of breath, weakness, fatigue, nausea, indigestion, anxiety, fear, and then that pain. Usually the pain is the factor. It's the worst pain they've ever felt, most people will say. So you will see some changes in enzymes. LDH1 is going to increase. CPKMB will increase. The only thing with anything CK is it can indicate muscle damage at any time. So that's not a whole factor by itself. It has to be in combination with other factors. Troponins definitely elevated. And AST is part of your liver enzymes. So you can see that going up as well. Complications of that MI are going to be sudden death. And again, most common cause of this is what? Sudden death from the MI. I just said this. What's the most common cause? Somebody heard me.
Are you referring to type 4 and 5
No,
for the
the
medical
cause.
procedure?
Types 4 and 5 are the types of MIs. What did I say the cause of death was going to be?
The atherosclerosis
Oh,
That's two different things. Atherosclerosis is
and
coronary
aroma.
artery disease. When someone has a heart attack or an MI, what is going to cause them to die after the fact? And especially if it's right sided.
Change in arrhythmia,
Yes, the
like VTAC or
arrhythmia.
V.
Okay, VTAC or VFib. It's probably going to be VFib. Better know that, guys. Other complications, cardiogenic shock, and the heart won't be able to recover because it's cardiogenic. So they're going to need help here. Congestive heart failure. Again, if this affects the left ventricle, that's my pump. If it affects the conduction system, how's it going to affect me? That's the right side. Rupture of necrotic tissue, cardiac tamponade. Cardiac tamponade is when we have all this fluid in the pericardial sac around the heart, and it compresses the heart to the point where it can't beat. Causes muffled heart sounds, changes in the blood pressure. And it'll lead to death if we don't correct it. Because the heart will literally stop beating. It can't beat. And also strokes. After left ventricular MI, heart's not pumping well, worrying about strokes now. What kind of things can cause conduction irregularities besides a heart attack? Hypoxia, too much potassium, acidosis, drug toxicities. I would know that. Cocaine users can suffer from fatal heart attacks because cocaine interferes with cardiac conduction. Cardiogenic shock if the heart's not able to pump effectively. All right, next is arrhythmias, and these come from interference with the rate or the rhythm. It can also come from electrolyte disturbances, fever, hypoxia, stress, infection, drug toxicity, anything that interferes with the conduction system. Somebody has rheumatic fever. That can lead to scar tissue and inflammation in the heart. If someone has an MI, this can cause a problem with conduction. So we use the EKG to look at conduction abnormalities. The problem with arrhythmias is the heart is not able to efficiently pump. Increase in the heart rate increases cardiac output, but the ventricles aren't able to fill appropriately because it's happening too fast. So it actually reduces cardiac output. If it's a slow rate, it can also reduce cardiac output. Irregular contractions are inefficient because they interfere with the filling and emptying cycle of the heart. And that is really, that all has to be in sync. All right, let's look at some of the abnormalities. All right, so the SA node could be damaged. It's the pacemaker of the heart. Bradycardia, this is a regular but a slow heart rate. Tachycardia is a regular but a rapid heart rate. And sick sinus syndrome is alternating periods of bradycardia and tachycardia. So a lot of times these clients are going to need some sort of a pacemaker. If you look at these different strips, you can see the top one is normal. So on the top one, you have your P wave, you have your QRS, you have your T wave. If you look at these ones below, they're missing. Each of them are missing different components, or there's extra components. One of the two. Now, bradycardia is usually less than 60. However, in an athlete or an older adult, that could be normal. Tachycardia is greater than 100, but the rhythm is usually normal. AFib, and I would know this one, okay? I think your book says more than 350 a minute. That's what you want to go with. And it'll be on the slide coming up. And then VFib is complete disruption. You're not having any cardiac output there. That's why with VFib, we have to start CPR and we have to shock them to put that rhythm back to normal, or try to reset that rhythm back to normal. So the most common types of arrhythmias, and I would know this, are atrial. A flutter is 160 to 350. AFib is over 350. The problem with AFib is pooling and thrombus, and they can form blood clots and die. Usually AFib is going to be fixed immediately. So if you go into AFib, they're going to put you in the hospital most of the time, the first time. Now they do cardiac ablations. I had 2, the second one worked. Sometimes the cardiac ablations don't work, but this is electrical activity coming in the heart from the wrong spot. So they need to go in there and burn it. And they burn the vessel, and then that electrical signal isn't able to generate from that spot anymore. So it stops it. But it doesn't always work on the first try.
What did you say that was called?
Cardiac ablation. So they'll regenerate the signal. They bring you in the cardiac cath lab. They regenerate the signal. You're awake while they do it. And once they generate where the signal's coming from, then they burn that area with a cauterized unit. And it stops that electrical signal from being able to produce there. Usually when someone has AFib or supraventricular tachycardia or something like that, the electrical signal is not coming from the SA node. It's coming from somewhere outside of the normal conduction system. So that's why they can use the cardiac ablation to fix it, because they can stop that electrical signal from coming in. They could stop that arrhythmia from occurring. But first, they have to get you out of AFib. So that's not the first steps that they do. Usually they'll try to convert the AFib back into a normal rhythm. And they usually do that with medication. So digoxin, metoprolol, things like that, that will slow the heart rate down. And then digoxin can actually convert the rhythm. There's some other drugs they might use too. Like amiodarone. If my heart's in sync, leave it alone. If it's out of rhythm, I might need amiodarone. Adenosine. Okay, if my heart's in SVT, beating fast like a machine, it might need something called adenosine. So this drug will slow it down. The amiodarone will bring it back into rhythm. Then they can give like the beta blockers to also keep it to a slower level. And the beta blockers can also help reduce the workload on the heart. So it's not working as hard. So they might give you a combination of all those. And then they're probably going to put you on some sort of anticoagulant. They may give you heparin to start with until they get your blood to a certain level and then switch you over to something. They're trying to get away from using Coumadin or warfarin because it's just a pain in the butt to deal with it. It constantly has to be reevaluated. So they're trying to flip over now to new anticoagulants. So that's why you see a lot of these other antiplatelet drugs and other types of drugs coming out. Heart blocks, okay, you have to know these. And the way I remember him is with the first degree heart block, okay? This is a young lady who's getting a little bit tired of her marriage. So she goes out, she stays out a little bit late because she don't want to come home, but eventually she does. So she got a little delay. She's coming home a little bit late. Second degree block, she's really getting tired. Now, every 2 to 3 days, she comes home. All right, so it's a much longer delay. And third degree block, she ain't never coming back. All right. In a third degree block, the signals just aren't getting there. Bundle branch. This is where you're not getting conduction to one of those bundle branches. VTAC. So with VTAC, that reduces cardiac output because it's reducing the amount of time for filling. Okay. So when the heart goes to contract, it's not going to have as much blood in it. VFib, the fibers contract independently, rapidly. There's uncoordinated quivering. This is the only way they describe VFib, okay? VFib is complete uncoordinated. So we don't have any cardiac output, and that's really going to cause the contractions to stop. Again, the person's going to die if you don't do something here. There's no circulation going out to the body. So this is why when you find someone unresponsive, what do they say? If there's no pulse, no breaths, what are you going to do? What's the best thing you can do? Remember, no matter who you are.
CPR, chest
Compressions, right? Compressions circulate the blood. And the reason why they want to make sure that when you're compressing, that you're going down 2 inches, coming back up completely to allow that recoil is because you're mimicking the heart. So when you compress, that's the contraction, right? But when you let it up to recoil, that's the refilling of that heart. So if you don't do both of those methods, you're not contracting and refilling the way the heart would. So it's not as effective. And that's why we want to make sure you're doing those compressions at a rate of 100 to 120, that you're completely letting that chest recoil, and that you're compressing those 2 inches or that 5 centimeters. PVCs, these are abnormal beats that can happen, and they can come from either ventricular muscle or from outside of the heart. But they can cause VFib over time. Most of the time, if there's only 1 or 2 here or there, they don't do anything to treat it. But if you have more than like 5 or 6 in a 1 minute period, then they would look at this. But there are additional beats that pop up. Now, which type of arrhythmias are the most common?
arterial.
Close. Atrial.
Oh, atrial, yeah.
This is just for your information, okay? They're not going to test you on this. But I want you to see what happens when we have abnormal electrolytes. Okay? This is a good one for the hypokalemia. I forgot I even had this on here. But you see how now you have that prominent U wave in the top? When you get to med surge, you're going to have to be able to read these. And you're going to be able to say, like, oh, yeah, this is caused by this. This is caused by this. But I just want you to see how the electrolytes can actually affect the heart. And none of these are good, by the way, because they all affect conduction. And in the right circumstances, could potentially lead to a death sentence for someone or a stroke. Cardiac arrest, here we have no heart activity, no impulse. EKG is flat. So there's a lot of things that could cause it. Excessive vagal nerve stimulation, potassium imbalances. Again, we're back to electrolytes. Cardiogenic shock. Remember I said that if the heart is damaged, it's not going to be able to compensate for this type of shock. And that could cause it to lead to death if we don't catch it and treat it. Drug toxicity, that's mostly going to be, it could be any kind of drug, but sometimes when people take things like cocaine or speed, in some cases, it actually has saved their life. Very strange cases. I wouldn't recommend someone to take it based on those reasons. But like, I know a gentleman that was in a head-on car collision back in the 1970s, and he had taken a lot of methamphetamines, and actually he would have died had he not been on those methamphetamines, because that's what actually kept his heart pumping. So there are some strange cases, when that can happen, but most of the time these drugs, especially cocaine and crack, over time they actually deteriorate the heart. So a lot of people end up with damage to the heart structure itself from taking these drugs. Also, because of the fact that they're street drugs and they can put any kind of junk in them, especially if they shoot like IV drugs, these drugs could lead to endocarditis, which you never want to have. That can really do some damage to the heart. Congestive heart failure. Here, the big bad pump is broken. So your heart is not able to pump out the blood to meet the demands on the body. Usually this happens because of some other condition in the body. It could be a lung condition or some other condition. It's usually chronic. And depending on the cause, one side of the heart usually fails first and then the other side. So, for example, someone could have an MI in the left ventricle, or they could have what we call essential hypertension. So the left ventricle is damaged first. Okay. But because of it putting an overwork on the heart itself, it eventually causes the person to also go into right-sided heart failure. Somebody could have pulmonary valve stenosis or pulmonary disease. Now, I said if you have pulmonary valve stenosis or pulmonary disease, what kind of heart failure are you going to have? Right-sided or left-sided?
Right-sided.
Right-sided. Okay, but over time, it can aggravate other things in the body, and eventually they could end up with left-sided as well. Increased afterload or increased blood volume. Increased preload caused by the kidneys secreting too much renin or aldosterone can add to the heart's workload. So why would the kidneys secrete too much renin or aldosterone? Well, they're getting low blood flow for some reason, because that's when the kidneys do that. Whenever the kidneys have low blood flow coming in, they're going to secrete more renin and more aldosterone. Okay. Because the body says, wait a minute, we got low blood flow coming into the kidneys. We must have low blood flow in the body. But that's not necessarily true. There could be other reasons why, like the person's in heart failure, so the blood flow is not getting out to the kidneys. Okay. There could be other reasons, and that's just going to precipitate the problem and make it worse, because the kidneys are getting low blood flow. They're going to keep trying to produce that renin and keep trying to bring the pressure up. And sometimes that is a problem. So it's just it's like with when we talked about COPD, how the body recognizes that it's just low oxygen and it keeps trying to produce red blood cells, but that's not going to fix it. It just makes it worse. The same thing here. The kidneys just recognize that we don't have enough flow. So it's just going to keep trying to make more flow happen. But more flow, more flow, more flow, the heart still can't pump it. So that's just going to put the person in fluid volume overload. Okay? You understand why now? Because the body keeps trying to compensate for what it thinks will fix the problem. But that's not going to fix the problem. You're still going to have low flow coming into the kidneys, because no matter how much fluid you have in the body, if the heart's not pumping it, it's not getting to what? If the heart's not pumping it, what's it not getting to?
The body?
Or those kidneys, right?
Kidney.
So even if you have all this fluid in the body and you're like, I don't understand, the body's not low on fluid, it's low on fluid it can use, because the heart's not pumping it. So then it ends up third spacing because there's nowhere for it to go. And it increases that capillary pressure. It increases other things in the body. So the fluid automatically goes to those areas now in that interstitial fluid. The sympathetic nervous system also will respond and increase the heart rate and peripheral resistance, which can decrease the efficiency of the heart and affect its ability to fill. It can also increase the workload on the heart. So the chambers of the heart will start to dilate. The cardiac muscle becomes hypertrophied, and the wall of the ventricle becomes thicker. This increases the demand for the blood supply to the myocardium. And eventually, some of those myocardial cells are going to be dying. And as they die, fibroids replace them. So that means we have less tissue now functioning there in that cardiac area. When the heart can't pump or maintain its pumping capacity, okay, less blood gets out to the organ because the output and the stroke volume is decreased. The cells aren't able to function as well anymore because they're not getting nutrition. The person starts to develop fatigue, lethargy, acidosis. They'll have backup and congestion. The coronary area or the muscular area of the heart is still going to put demands on it, but the body's not able to meet those demands for oxygen and glucose. The output is less than the input. And so now we start to see congestion, and it'll also affect the heart. So the body will increase respirations and try to compensate. The affected ventricle, however, is not able to pump the blood. The return of the blood to that side of the heart is impaired. This is called a forward effect. Backup congestion develops in circulation behind the affected ventricle. The output from the ventricle is less than the input of blood. For example, the left ventricle cannot pump the blood into systemic circulation. The normal volume of blood returning from the lungs cannot enter the left side of the heart. This causes congestion in pulmonary circulation, increased capillary pressure, which leads to pulmonary edema. Fluid is forced into the alveoli. This is called left-sided heart failure. In right-sided heart failure, the right ventricle cannot maintain output. So left blood goes to the left side of the heart and systemic circulation, which is a forward effect. Congestion is apparent as shown as an increased blood volume and congestion in the legs and the feet, also in portal circulation, where the liver and digestive tracts are, as well as those distended neck veins. So again, this picture here is showing you left-sided. Versus right-sided. So go and look at those pictures. Get this stuck in your brain. All right, so with forward effects, We'll have decreased blood supply to the tissue, hypoxia, fatigue, weakness, shortness of breath, tachycardia, oliguria. With backup effects, we're going to have pulmonary congestion, orthopnea, cough, that paroxysmal nocturnal dyspnea. I would know this. This is when you wake up in the middle of the night coughing. You feel like you can't breathe. You're short of breath. Right-sided failure versus left side, you need to know. So right-sided is going to be in the body, the feet, the legs, the buttocks, edema. Pressure in the jugular veins, causing them to be distended. Enlarged liver and spleen, ascites, also from the liver, the spleen, in that peritoneal area. And they'll have a red face or a flushed face, distended neck veins, headaches, and visual disturbances. So this is just talking a little bit more about forward versus backwards. Just review the slide, okay? Right-sided versus left-sided. Review this. Look at the differences and know them. In kids, okay, congestive heart failure is usually related to some sort of congenital disease. These kids are going to have difficulty feeding, difficulty gaining weight, and they won't be able to meet the developmental guidelines. With adults, you'll usually see weight gain. But kids, their metabolism is already high. This is young kids. So they already need a lot of food to maintain that. If they're sick, they need more. So this is why they don't often gain weight. They'll be irritable. They'll have short sleep periods. They may tripod, meaning they can't breathe or can't breathe well. Grunting is also a sign of respiratory distress for them. X-rays will show a large heart, and the ABGs will show hypoxia. I would know that these anomalies start in the first 8 weeks of embryonic life. So as that baby's developing, those structural defects will develop as well if they have this. Congenital usually includes defects with the valves, septal defects. Remember, that's that septal wall we talked about. And that will show in the way of murmurs because both valve defects and septal defects cause murmurs. If we don't treat it and it's severe, then the child can develop heart failure. The disorders could cause cyanotic or acyanotic, meaning these may be blue babies or they may not be blue. And that depends on how the blood shunts. So if they have a large defect, they may have things like color problems, like pallor, tachycardia, shortness of breath. For squatting positions, usually you see this in babies with cyanotic deficits like tetralogy of Fallot. There's 4 defects there. Club fingers. Okay, this is long-term heart issues. Intolerance for exercise or cold weather. Delayed growth. So ventral septal defect is the most common congenital. Here they have an opening in the septum. If it's untreated, the pressure is usually higher in the left ventricle, so the blood will shunt from left to right. This is acyanotic unless the person has a problem with the respiratory system. Valve defects. So we can have mitral valve prolapse where the valve doesn't completely close. We can have stenosis where it's narrowed. Either way, it causes a problem. Okay, the valve doesn't close completely. Blood can regurgitate or leak backwards, or it's harder to get the blood through. With prolapse, the valve is usually enlarged and the valve is floppy. Either way, it's still going to cause the blood flow to go backwards. So usually they have to get a new valve. This is just showing you the difference, okay? So for stenosis, the blood goes through, but it's hard to get it through because it's narrow. With incompetent, the blood or regurgitation, the blood can flow backwards or regurgitate. Tetralogy of flow, I would know this. They have 4 defects. Pulmonary stenosis, which is usually caused by the which usually causes the right ventricular hypertrophy. Sorry. The pulmonary stenosis, okay, that's that pulmonic valve and it's stenosed, meaning it's hard for the blood to get through. Since that blood's coming from the right ventricle, it causes right ventricular hypertrophy. Then they also have a defect in the ventricular septal wall. And they have an overriding aorta. It's not sitting where it's supposed to. All right, so for tetralogy of Fallot, most of the time, that's going to be the major issues. And the problem is these babies are cyanotic because the blood's mixing. They're getting a combination of both oxygenated and unoxygenated blood. So that's why they have those hypercyanotic episodes where they have to squat or the nurse has to grab them and pull their knees up to the chest. All right, I don't think we're going to get to rheumatic heart disease today. I'm going to stop here. I will try to go over this for you guys again at some point. But go through this because you do need to know rheumatic fever, how it affects the heart. You're going to have to know about endocarditis, pericarditis, and those valve disorders, which a lot of that stuff I've talked about, and shock. Okay, if you guys can stay on here, if you can give me about 5 minutes, I might be able to stay on a couple more minutes and go over a couple more things. I have an appointment coming, but they're not here yet. So just give me about 5 minutes and I'll try to see what else I can get to.
Okay, thank you.
Okay, so let's talk a little bit about rheumatic fever. Rheumatic fever is a systemic inflammatory infection, and it happens usually from an abnormal reaction right after some sort of untreated infection, like a group A hemolytic strep infection. The inflammation is going to affect the heart, your joints, your skin. It usually happens in kids between 5 and 15, and it can have long-term effects that are seen in the form of rheumatic heart disease. And it can be complicated by something called infective endocarditis and heart failure, especially in older adults. So usually they have this infection like an upper respiratory tonsillitis or strep throat. Antibodies to the strep form as usual, but then they start to react with connective tissue there in the skin, the joints, the brain, and the heart, and that causes inflammation. The heart is the only place that will see scar tissue forming, and that causes rheumatic heart disease. In the acute stage, the inflammation in the heart can involve either one or all three layers. Pericarditis is when there's inflammation in the outer layer, and this can include effusion, which is excessive accumulation of fluid there that impairs the ability of the heart to fill. It can affect the muscular layer or cause myocarditis, and this is when we see lesions in the heart and these things called Ashkoff bodies. And this myocarditis with these Ashkoff bodies can interfere with conduction. So that means they can develop arrhythmias. Endocarditis is the most common issue. The problem with that is it affects the valves. It causes them to become edematous, and it causes verrucae, which is like a vegetative growth, to form on the outside of it. The mitral valve is the one that's most frequently affected. Inflammation will interrupt the flow of blood and the effectiveness of the left ventricle. The valve can also become scarred. So once that mitral valve is scarred, it can become stenotic or incompetent. Recurrent inflammation is more likely to happen because the valves are now damaged. So that puts the client at a high risk for infective endocarditis. Other sites of inflammation in clients that develop rheumatic fever are the large joints, especially the ones in the legs, and that's going to be in that synovial joint area. So it causes that synovitis, or that inflammation of the synovial fluid. The skin might have a non-pruritic rash that looks red. The wrists, the elbows, the ankles can sometimes be affected. And in the brain, the basal nuclei. And that basal nuclei, remember we talked about that early on as being responsible for movement. So that can cause them to have these jerky movements in the face and the legs. And it's known as chorea or St. Vitus dance. So signs and symptoms of that rheumatic fever are going to be low-grade fever, increase in the white blood cell count, malaise, anorexia, tachycardia, heart murmurs, nosebleeds, abdominal pain. This is the actual inflammation of the mitral valve. And this is when it's stenosed. As you can see, there's not a very big place there for the fluid to flow through. It's just that little hole right there on the left. And all your blood has to go through that. So, what you have to remember is they get this group A infection and it's not treated. My CEO actually died from this because he had an infection, a strep infection, and he never got it treated and it killed him. But they have this group A infection. It goes untreated. It causes these antibodies to form. The antibodies have a reaction with the collagen. That's why it's affecting the joints in the skin, the brain. Inflammation in the heart develops. Pericarditis, which is the outer sac, remember, with the fluid. The myocarditis with the Ascough bodies, that's that muscle layer of the heart, and that can cause arrhythmias. And then the endocarditis, which is the worst of all, with that valve damage. So now that can affect the blood flow, and those vegetations can now grow on the heart, okay, around where those leaflets are. Scar tissue can develop there. A lot of times they'll have to have the valve replaced. Okay, infective endocarditis. This used to be called bacterial endocarditis. There's two forms. It could be subacute, where the heart valves that are defected are invaded by organisms like strep. Usually these are lower level, low virulence, so they don't attack as hard. And a lot of times it comes right from the mouth. Dirt in the mouth, those germs in the mouth. Acute, which attacks normal heart valves. These are a lot more virulent, and they can come from staph also. But these end up causing tissue damage, and they may be hard to treat. Both of them will have the same effects. Both of them can put people at risk for infection, and they can develop bacteremia, which means the bacteria is now in the blood. But things that put them more at risk, okay, are having immunocompromised system, having abnormal heart valves, or already having that bacteremia infection. So usually with subacute, it's going to be a slower onset, low-grade fever, fatigue. They'll have anorexia, splenomegaly, and something called Osler's nodes, which are these red, painful nodules around the joints in their fingers. Septic emboli from the vegetations that cause occlusions in the vessels and abscesses in other parts of the body, and bacteria releasing into the blood. They can also develop congestive heart failure. With acute endocarditis, it comes on quickly with the spiking fever. Drowsiness, the heart valves are usually damaged pretty bad, so the heart's not functioning that well. This can cause, again, emboli to develop in other areas and cause infarctions or abscesses. We usually have to do a blood culture here. Pericarditis, this is usually in response to some other condition. It can be acute or chronic. And again, that's usually affecting that fluid around the heart. They can develop an effusion, which is a large amount of fluid in the pericardial sac. This can lead to distended neck veins, faint heart sounds, and pulsus paradoxus. A lot of times what happens there is they develop cardiac tamponade, which also has those symptoms. Contributing factors to the pericarditis can be things like open heart surgery, and MI, rheumatic fever, cancer. And with pericarditis, we'll have fluid around the heart, compressing it. The heart's not able to expand or fill. It backs up into circulation in the system. We have a decrease in blood flow to the lungs and a decrease in cardiac output. Chronic pericarditis can result in adhesions forming that become constrictive and affect the ability of the pericardium to move. It can lead to fatigue, weakness, abdominal discomfort, venous congestion, and cardiac tamponade. Again, those symptoms of the distended neck veins, faint heart sounds, pulsus paradoxus, those are all cardiac tamponade signs. All right, valve disorders. So let's start with arterial diseases, high blood pressure. It can be primary or secondary. It's considered a silent killer. It can be classified as diastolic or systolic. It's categorized in 3 manners, okay? Primary or essential, secondary, and malignant or resistant. Essential hypertension is when it's 140/90. This can be adjusted a little bit for age. The diastolic is most important because that tells us about the amount of resistance and the increased workload of the left ventricle. It can be mild, moderate, or severe. With essential hypertension, we have an increase in arterial vasoconstriction. A slight decrease in the diameter of the arterioles also causes an increase in peripheral resistance, reducing the capacity of the system, increasing diastolic pressure or afterload. Vasoconstriction causes a decrease of blood flow through the kidneys. And remember, that decrease in blood flow to the kidneys is going to cause an increase in what? Come on, I just talked about this 10 minutes ago. Low flow in the kidney is going to cause an increase in what?
Blood pressure.
Renin?
Yes, blood pressure through the renin. Thank you. Renin, angiotensinogen, and aldosterone. Okay. Whenever you have low blood flow going into the kidneys think that it needs to bring in more volume and it needs to vasoconstrict in order to bring the blood pressure up. That's the kidney's job, is to maintain that blood pressure. So whenever there's low flow coming in, it doesn't matter what the reason is, because the kidneys don't have that ability to think. It just recognizes there's low flow. So it says, hey, it's low flow coming in. If I can produce more renin and bring in more volume, I can increase the pressure. Okay. So it'll keep increasing the pressure in response to that low flow, even if the body doesn't need it, because that low flow is recognized as coming in. Over time, increased blood pressure causes damage to the arterial walls, causing them to become hard and thick and narrow. This can cause them to tear and form aneurysms. It can also cause those atheromas, or those pieces of plaque and stuff, to form and break off. It reduces the blood supply to the area. That can cause ischemia, necrosis, and loss of function. Secondary hypertension usually comes from some sort of kidney or endocrine issue. So like nephrosclerosis, where the arteries going to the kidneys are damaged, or a tumor like pheochromocytoma, where you have a tumor on the adrenal medulla, or hyperaldosteronism, where the body's producing too much aldosterone. In that case, we would have to treat those problems in order to fix the issue. Malignant or resistant hypertension is the third type. This is an emergency with extremely high blood pressure. And with this, we will see typically organ damage to the central nervous system and the kidneys. The diastolic pressure is always usually high here as well. Again, this is just showing you about what we just talked about. Okay. The arteries going to the kidneys might be damaged. And so, because of that, we have a decrease in the blood flow to the kidney. The kidneys don't know what's up. All they know is they're not getting enough blood. So, they're going to try to get more blood to themselves. So, they're going to produce that renin. Okay. So that they can try to get that blood flow moving. So when someone has high blood pressure, the areas that are most frequently damaged are going to be the brain, the retina, which we've talked about, okay, the heart, the kidneys, the brain, things that can cause this, an increase in age. Men are typically affected more than women. Certain genetic factors, like being African American, increases in your sodium intake, drinking too much alcohol. So, like, you could have a glass of wine or 2 glasses of wine a day, one if you're a woman, one if you're a man, and they say that's okay. But if you drink a whole bottle every day, then that's what they would consider excessive, and that could actually increase your chances for this occurring. Obesity, smoking, and prolonged stress. Remember, prolonged stress also affects the kidneys and damages them, which can affect your blood pressure. So a lot of times they won't have any signs and symptoms. If they do, they're just tired or they don't know why, or maybe they have a morning occipital headache. Blood pressure will be consistently elevated. So that's why they do 2 or 3 checks. Okay. Next is shock. Hypovolemic shock is when you lose circulating blood or blood volume. So, like, you have a bleed, or you have a miscarriage, or you lose fluids because of excessive diarrhea or something like that. Okay. Cardiogenic shock is when the heart is not able to pump and maintain that cardiac output. And distributed, vasogenic, neurogenic, anaphylactic, they fall in the same category. This is where the blood pools and it's not able to get out to the organs. Anaphylactic can cause a cardiac issue, okay? And usually this is from some sort of allergy. With septic, that can lead to death. A lot of times people will get that septic shock, okay, and they can't recuperate. This is caused by some sort of bacteria in the bloodstream. Symptoms are going to be less cardiac output. Blood flow going out is decreased to the organs. Reduced oxygen and nutrients available for the cells, leading to anaerobic metabolism. So when we do anaerobic, we're doing it without oxygen, and this causes lactic acid to increase in the body. That increase in the lactic acid can lead to metabolic acidosis. Clients will have anxiety, tachycardia, color changes, pallor, because the blood flow is not getting out to the skin, lightheadedness, syncope or fainting, sweating, and oliguria, where they lack urination. All right. In compensated, they're okay. They can usually recover. In progressive, it's going to get difficult now. We may have to do some big moves here. Okay. In decompensation, they're going to die. So usually we'll see that a lot in septic shock. Okay. Septic shock isn't handled right away. They're going to die. That's what you see, like what most of your African American women, when they die after childbirth because of an infection, they end up in septic shock and they get to a point where we can't reverse it. And it's really ridiculous because there's no reason why it should be happening in this day and age. But people still aren't paying attention. They're still not doing what they're supposed to do. And I'm talking about the people in the healthcare industry. Organs cannot compensate for the problem if they're the source. So remember, for cardiogenic shock, it cannot be compensated by the heart because the heart is not able to increase that cardiac output. Waste will accumulate in the body. That will lead to lower pH. It can cause acidosis. And if that shock is not reversed quickly, it's going to become harder and harder, and these people are likely going to die. All right, so know your signs and symptoms. So how does the body compensate? So the sympathetic nervous system and the adrenal medulla will be stimulated. Remember, that's going to release epinephrine, norepinephrine. Your body's under stress, so your cortex is going to release the cortisone. All right. Your kidneys here are probably going to release renin, angiotensinogen, aldosterone to try to help us recoup more volume, more vasoconstriction, ADH to help us reabsorb more water. The cortisol, okay, cortisol, how's that going to help us? It's going to help give us energy, help increase our alertness a little bit. And then the acidosis, which will stimulate our respirations. But if we don't fix it, these people will end up dying. All right, so I would pay close attention to this slide here. All right, early signs, progressive signs, and then your final sign here, they're going to end up in MODS, okay? Multiple organ failure. So this is just kind of telling you what happens, when that happens. And these are from the what you think questions in your book. That's it. We did it. We got through it all. Questions? Any questions on anything I went over today?
Can you go over the heart one more time?
Okay, so here we go. 2 types of circulation, pulmonary. That is what's coming into that right atrium and then to the right ventricles and then into the lungs so that it can be oxygenated. Systemic circulation is what's coming out of the left ventricle into the aorta and out to the body. You got 4 chambers. The 2 upper chambers are the atria. The 2 lower are the ventricles. Okay. On the left side, you have the mitral valve. On the right side, you have the tricuspid valve. And the lub-dub sound is generated by the closing of those semilunar valves. Normal blood flow through the heart. So from the superior and inferior vena cava into the right atrium, you have that unoxygenated blood coming from the body. Once it comes into the right atrium, it's going to fill that right atrium completely up. At the same time, on the left side of the body, you have the blood coming back from the lungs into the left atrium. And it's oxygenated now because it just left the lungs. So it's filling up the left side of the heart. Both atrium will fill up completely. All right, as they're filling, before they started to fill, okay, that SA node already set that first impulse out and it got to the AV node, right? Or it's on its way there. So once these 2 atrium fill up all the way, they're going to force the valves open. The right atrium will force the tricuspid valve open. The left atrium will force the mitral valve or bicuspid valve open. Now fluid goes into the ventricles, the right and the left. They're both filling. So that signal that went from the SA node to the AV node is now delayed and sitting there waiting on these ventricles to fill. Okay, when the ventricles get close to being filled, that AV signal is then going to travel down the bundle of his to the Purkinje and the terminal fibers. These ventricles are going to fill all the way up, and the tricuspid valve will close on the right side. On the right side, and the mitral valve will close on the left side. Okay, now they're all full. The signals went all the way through to the end terminals. They'll simultaneously contract. From the right ventricle, blood will go into the pulmonary valve and into the pulmonary artery. So now you have the pulmonary artery bringing that deoxygenated blood into the lungs, where it'll go into the alveoli and be exchanged. When it leaves the alveoli, it's going to go through the pulmonary vein back into that left side of the heart. Now, we already talked about it coming in. It's in that left ventricle, okay? When that left ventricle contracts, it goes into the aortic valve. From the aortic valve into the aorta and out to all the arteries in the heart to send that oxygenated blood back out to the body. On the right side of the heart, you have the tricuspid valve. You have the pulmonic valve. If those valves become stenosed or incompetent, it's going to cause right-sided heart failure. If you have some sort of lung disease, it's going to affect the right side of the heart. On the left side of the heart, you have the mitral valve. You have the aortic valve. And the left ventricle is your big bad pump, which is pumping against resistance in the body. So if you have high blood pressure, if you have an aortic problem, if aortic valve problem, if you have a mitral valve problem, that is going to lead to left-sided heart failure. Other things that could cause heart failure or problems. A heart attack on the left side of the heart could affect its ability to pump. A heart attack on the right side of the heart would affect its ability to conduct a normal rhythm, because it can interfere with the pacemaker and all that, which is in the right side of the heart. So right-sided heart issues typically can cause arrhythmias. Left-sided in that ventricle, okay, is going to be definitely flow out to where? The body. Okay. However, what symptoms are you going to see? So when the heart is in failure, the fluid going into the left side of the heart is coming from the lungs. So that's why when you have left-sided heart failure, the fluid backs up into the lungs. That's why you see things like shortness of breath, pulmonary edema, fluid. So we're talking about symptoms now. When fluid backs up on the right side, or when there's damage on the right side, you're going to see it in the body, because the blood coming into the right side of the heart is coming from the body. Got it?
Yes, thank you.
All right. Have a good day, guys. Any other questions? Somebody was supposed to wait on here for me. Are you here? Okay. That's it then. See y'all
Have a
later.
good one. Bye-bye.
Thank you.